Hello, everybody. We're just going to wait a minute while people log on and we'll get started. Okay, very good, everybody. Thank you for joining us. Thank you for being part of this seminar. For those who I do not know, I'm Sandro Galea. I have the privilege of serving as Dean of School of Public Health at Boston University. And we're putting on this seminar for friends of the university around mental health and mental health in the context of the COVID-19 epidemic. We did a similar seminar 2 weeks ago about the state of the science. And at President Brown's request, we are doing the second seminar around mental health. We see mental health as the next wave of this epidemic. And as you'll hear from myself and the co-presenters, you will see that the evidence strongly suggests that that's something that we should care very much together as a community. A couple of technical notes. For those who need them, you can use closed captioning with this. There's closed captioning. You can just simply click at the bottom of your Zoom where it says CC, and you will see closed captioning for any of the speakers. We also will take questions at the end. The format is each of the speakers, we're going to speak for about 12 minutes each, and that should leave us 20-25 minutes for questions. Please use the Q&A function, not the chat function for questions, just easier to manage, and I will do my best to triage all questions, and we'll take questions very quickly from our panelists. So having said that, I'm going to be the first speaker. I'm going to share my screen. And good. Can everybody see the screen? Jaimie, can you see my screen? Very good, thank you. So today's topic really is mental health and COVID-19. I'm going to really do a very top-level overview of mental health and COVID-19 and in 6 points. And I'll hopefully set the stage for what Professor Lipson is going to say and Professor Gradus is going to say. Now, I'm going to summarize the evidence that we do have about mental health after COVID-19, but as everybody might expect, we do not have very much about COVID-19 yet. But we can draw a substantial amount of inference from previous studies, and particularly when we think about COVID-19 as a trauma. Now, this is a definition of a traumatic event, and I've used this definition for decades, really. And a traumatic event is an experience that causes physical, emotional, psychological distress. It's an event that's perceived and experienced as a threat to safety or stability of one's world. And when I went back into my files, when COVID-19 started happening, I was struck by how opposite this was to COVID-19, because we all recognize that this is an event that's causing us physical and emotional distress that is threatening the safety and stability of our world. So when you think of it this way, you realize that COVID-19 is a paradigmatic trauma. It is a trauma that we're experiencing. Now, I've studied traumatic events in individuals and in populations for about 20 years, and I've studied many large-scale events, things like Hurricane Katrina, September 11 terrorist attacks, the wars in Iraq and Afghanistan, but I've never studied an event that has affected as many people around the world as this one. So this is a traumatic event, but a traumatic event with much greater breadth than any that we've previously experienced. So having said that, then there are 6 points that I'm going to make today. And really, I'm just going to show you a little bit of data about each of these points, and I'm going to lead you through point by point. Let me start this way. We know from prior evidence that when traumatic events happens, there is an increase in mental illness after these traumatic events. And I could show you, I could spend a whole hour of a talk. I do an hour talk about that, really talking about the evidence and previous evidence and the increase in mental illness that happens. But I'm just going to show it to you very, very simply. This is a picture, which is a color density graph of post-traumatic stress disorder after the 9/11 attacks in New York City. And I want to show you a couple of things. First of all, that there was a high prevalence of post-traumatic stress, particularly in Manhattan, which you can see in the middle of the screen. I think I can show it to you with the cursor. And but you also see that the color sort of dims as you go out from where the World Trade Center was. And that's a pretty typical pattern for the density of mental illness after traumatic events. that it's higher close to where the trauma happens, where the terrorist attack happens, where the hurricane happens, where the flood happens, and then gets less and less when you go further away from it, which in many respects is entirely rational. I don't think I'm saying anything that surprises you. But what I would challenge the audience to think is, well, what does that mean in the context of a traumatic event that is being experienced throughout the world? And there is no epicenter. I mean, obviously there are cities that are epicenters, but even if in New York City, I mean, here I'm showing you radiating lower prevalence of post-traumatic stress from one site, the World Trade Center site. We're dealing now where the entire New York City is in and of itself at ground zero. So we can reasonably expect that the higher prevalences will be in much larger geographic areas than we've ever had around the world after traumatic events like this. So point A, evidence from prior events suggests increase in mental illness. Point B, there are some studies that are emerging that are consistent with this evidence after COVID-19. Most of them are from China, as you might expect, and I'm going to show you some early evidence from the US. So this is from the first paper that came, this is from a paper after prior traumatic events, which in this case was Ebola. So it's like the previous pandemic. So this is after Ebola and showing the prevalence of anxiety, depression symptoms, PTSD, or comorbidity. Just focus on the right where it says comorbidity. What you see is that nearly half people in this study, which looked at Sierra Leone, mental health of Sierra Leoneans after Ebola, had reported symptoms of anxiety, depression, or PTSD. So this is after the Ebola epidemic in Sierra Leone. So this now starts moving from prior evidence to pandemics. Now, let me move to today. So this is probably the best study that's come out so far about mental health in the context of COVID-19. And the way to read this is we're dealing with normal, mild, moderate, and severe. And we're dealing with, the study looks at multiple things, but we're talking about depression here for a second. And what I want you to see is the different color bars. So Wuhan is the darker bar, Hubei is the province where Wuhan is in, and the orange is outside of Hubei. And the higher the bar means you have more people in that particular bucket. So Wuhan is where the epidemic happened more. And what you see is there are fewer people in the normal range in Wuhan, fewer than Hubei, fewer than outside Hubei. And as you get to mild, moderate, severe, you have more and more people in the Wuhan category. Severe is roughly the same, but severe now we're dealing with lower numbers. So essentially, the curve of depression is shifting, that more and more people in Wuhan have depression than in Hubei, which is where there was less COVID, and outside Hubei, where there was even less COVID. This is from another study that just came out, which looked at the forces that were driving mental health and mental illness during COVID-19. And all I want you to look at is at the bottom of this, at social media exposure. All I want you to see is these lines really represent risks. So when you have the line to the right, you see the very bottom line where it says frequently, there's a dot around number 2. That just means twice the risk. And all I want you to see is social media exposure. The more social media exposure, the more the risk for poor mental health symptoms. In this case, it was depression and anxiety. And that is consistent with other studies. And the reason this is relevant is because if 9/11 was the first real-time televised traumatic event, which broadly speaking it's well recognized, this is the first global scale, real live social media experience traumatic event. And what you're seeing is more social media exposure, the higher the risk of mental illness. And of course, everybody is largely being exposed to more social media exposure, which is going to have real implications for mental illness after this event. And these are really fresh data. We ran this yesterday. So we at Boston University have run a national survey of the mental health consequences of COVID, and we're just getting the data right now. And this looks at depression. And all I want you to see is the blue are national data before COVID. The orange are data that we're getting in from the study. So this is really preliminary because we haven't finished the analysis. But all I want you to see is normal, which means no depressive symptoms, mild, moderate, severe depressive symptoms. And the blue is before COVID, the orange is after COVID. And you see far fewer people in normal, more people in the mild, more in the moderate, more in the severe. So really very similar to what you see in the Wuhan, the Hubei picture, only this is actually more dramatic than what you saw in Wuhan and the Hubei. These data will be analyzed and will be submitted for publication sometime in the next week. And then I want to show you this. This is also from the same study. These are number of depression symptoms. So the way to read this is you see 0, 1, 2, 3, 4, 5 at the bottom. these are number of depression symptoms. And the blue, again, is normal time. The orange is COVID. And so you start with the 0. You see number of people who had no symptoms and in before COVID and then after COVID. So you see there are many more people before COVID with no symptoms, far fewer people now. And as you go along to the right, you see there are more and more people with more symptoms now. And that's really what's going on. Epidemiologically, we call this shifting the curve because you're shifting the whole population. So we have more and more people with symptoms of depression, which is going to become more mental illness. So that's point 2. The emerging evidence suggests that we're going to have a dramatic increase in mental illness worldwide. Number 3, a lot of this is happening on top of an economic downturn, which is really going to compound the influence of COVID-19. Everything I'm showing you has been about fear and threat from the virus. The long-term consequences are going to be driven by long-term consequences, largely driven by the economic downturn. Very briefly, this is just a sort of a reminder of the enormous shock to the economy. We've had 6.6 million people have filed for unemployment in the latest numbers. And just to remind us, that 6.6 million is 10 times higher than the most number of people had ever filed for unemployment before, which was in 1982, which is really impossible to even wrap your brain around. And we know that economic consequences are linked to mental health consequences. Again, I could spend an hour talking about that, but just to show you one slide, this is from a slide looking at risk for suicide. And this looks at economic indicators in New York State in a study we had done. And the way to read this is you go on the x-axis, you go further to the right, the better the economy. And the y-axis is suicide deaths. And what you see, the economy gets better, suicide rates go down. And I could show you that for many other mental health conditions as well. Number 4, a key part of this picture is ongoing stressors. A key part of this picture is that the trauma itself, if we take COVID as the trauma, will result in mental illness. And that mental illness is then propagated and pushed forward and maintained by ongoing stressors. And to show you this, I'll just show you this one picture. So this is data from a study after Hurricane Katrina. And everybody in this graph developed post-traumatic stress disorder after Hurricane Katrina. And then we follow them forward in time. The x-axis is number of days. So you see 200, 400, 600 days. So we're dealing with 2.5 years here. And there are 2 lines. The lines really are about resolution of PTSD, which means your PTSD goes away, either it gets better by itself or because of treatment. And you see there's a bottom line, which is low stressors, and the high line, which is high stressors. The high line means people who kept having PTSD for a long time. The stressors here were things like having a hard time paying the mortgage, having a hard time looking after aging parents, having a hard time having kids in school, having marital difficulties. So what it shows is that when you have onset of mental illness, things like post-traumatic stress disorder, which is a disabling condition, that onset and the course then is affected by ongoing stressors. And one of the big worries that I think we face collectively now is that in the context of an economic recession, we are all going to be facing those stressors, and that's going to affect the course of mental disorders. Number 5, we talk about mental health, and the seminar is about mental health, but mental health is inseparable from physical health. It's really impossible to say that we should only look at mental health, and we need to think of mental health and how it affects physical health. Let me show you just a couple of graphs on that. This is from a study that we had done some years ago. And what this looks at is diabetes. And it says your risk of getting diabetes over time. On the x-axis, you have age. So you see, as you get older, you see all these lines go up. As we get older, our risk of diabetes goes up. We know that's true for everybody. But now what I want you to look at is the colored lines. So the black line, which says no trauma, is the bottom line. So you see, you haven't had a traumatic event, that's fine. Your risk of diabetes goes up with age. But look at the lines. You move to the red line, the yellow line, the blue line, and the purple line, and the lines get steeper. Those lines are people who've now had symptoms of post-traumatic stress and have had a traumatic event. So having had a traumatic event, having had symptoms, means your risk of diabetes goes up. So in the increase in mental illness that we can expect, we can also expect an increase in physical health that's directly linked to mental health. And the other aspect of this, which I wanted to talk about briefly, is that one of the challenges that we're going to have in terms of mental health and physical health is that we are being distracted now by COVID appropriately, but as we're being distracted by COVID, many other conditions are also accumulating. This is actually from the Ebola epidemic in Liberia, Sierra Leone, Guinea, and all of them together. There are different countries. The bottom right, look at panel D. Panel D is combining all the countries who were affected by the Ebola epidemic. The green, you see those green and blue curves, those are actually the Ebola epidemic. The other bars are not Ebola, they're malaria. Now, malaria is obviously endemic and it's really dealing with West Africa. But the point is that you see how Ebola came and went, and malaria was also going up with Ebola. While the Ebola went down, then there was another wave of malaria cases. And that is simply the fact that within our health system, because we're not resilient to these large shocks to the health system, as we're not resilient to COVID, other diseases then get out of hand, and we do not keep track of these other diseases. And that's exactly what we saw happen after Ebola, and that is broadly what we're starting to see happen now. You're starting to see newspaper articles about more people dying from heart attacks, for example, and that's because our health system is now not keeping up with those. I'll actually skip that one in the interest of time. This makes the same point. And number 6, these mental health consequences are long-term and lasting. And these mental health consequences go on for years and years. And I just want to show you this with one particular slide. This is from a study that we had done some years ago in West Africa, in Liberia. And all I want you to see is this is a province in Liberia. Those numbers, those circles with numbers, are where there was war 20 years before we did our study. So these were places where there was war 20 years before we did a study. 20 years later, we did a study, and you find those big dark circles which show the real density of post-traumatic stress, depression, and anxiety. So 20 years after the conflict, you have the same pattern. Essentially, you had a path of trauma that was carved through the countryside, in this case, that was directly linked to the conflict 20 years earlier. So unfortunately, these conditions do last and do last for a long time. 7th point, which I'm not going to make, but I did want to end on this point, is actually we can mitigate some of these consequences. So I put it here because I want to preface what Professor Gradus is then going to talk about. She is going to talk about treatment approaches and how we actually mitigate some of this, but I thought it would be a little bit too depressing for me to end by saying it's only a problem, but there are things that we can do in some of this. So I will stop there, and I will introduce our next speaker. Our next speaker is Professor Sarah Lipson, who is a professor in our Department of Health Law, Policy and Management. And Professor Lipson's area of expertise is particularly mental health among college-age students, which we thought was particularly relevant for this seminar, given that this is all part of the BU family. Professor Lipson, let me stop my screen share so you can take over.
Great. Thank you very much. I'm very happy to be here today and have a chance to talk to everyone about something I care a lot about, which is the mental health of college student populations. College students represent a really significant population with regard to mental health. From a psychosocial and developmental perspective, the college years are really significant, a time for newfound autonomy. The age of onset for mental illnesses coincides with the traditional college years, so 75% of lifetime mental illnesses will onset by age 25. For adolescents and young adults, the greatest burden of disease of any health condition is mental health. And the good news, or the thing that really motivates my work, is that campus settings offer a really unique opportunity for prevention and early intervention during this vulnerable time. So more than 22 million adolescents and young adults are enrolled in US post-secondary education, meaning we have access to this vulnerable population. And then adolescent and young adult mental health, and specifically mental health during the college years, is an important predictor of almost every outcome that we care about throughout the life course. So mental health is predictive of economic, educational, and social outcomes. I saw this, I think, last week, and it really resonated with me in terms of trying to understand the perspective that college students and young people have today. And I'll just read it quickly. It says, if 20 formative years of your life involve a major terrorist attack, 2 recessions, exorbitantly expensive and unnecessary wars, tangibly worsening inequality and emergencies, and incompetence during a global pandemic, it might make you think things aren't good. So with that context, I'm going to talk about 3 things. I'm going to start with kind of the underlying data and what we know about mental health on college campuses prior to the coronavirus pandemic. So here's some prevalence data before COVID. And I'm always careful to include this first row of data, which is flourishing. So students who are thriving, positive mental health. And you can see that about 40% of students in a national survey that I run called the Healthy Mind Study are flourishing, are doing really well. I've also included data from the most recent administration of the Healthy Mind Study at BU, so for a comparison. And you can see that roughly a similar percentage, 42% of BU students are flourishing. Depression is measured using the Patient Health Questionnaire 9. You can see 36% of students in the national sample in the most recent year screened positive for depression, a little bit lower at BU. For anxiety, 31% are screening positively for clinical anxiety, 14% are reporting past year suicidal ideation, and 24% are reporting past year non-suicidal self-injury. One of the most common questions that I get asked is, are the problems getting worse over time? And this is a map of colleges and universities that have participated in the Healthy Mind Study in recent years. It's about 350 campuses and over 300,000 students who've completed the survey. And I'm going to share a little bit of trend data over time. So we can see from 2007 to 2018, a significant increase in symptoms of major depression. Similarly, an increase in levels of severe anxiety in recent years. And one of the most important things, and something I'm thinking a lot about, is there are known risk and protective factors for mental health in college student populations and for populations writ large. And looking at these risk and protective factors with new eyes in light of COVID-19, I think really underscores the urgency as well as the opportunity that we have on college campuses. So risk factors for mental health: isolation, financial stress, and negative health behaviors such as poor sleep, substance use, and certain use of technology and social media. Of course, technology I'm going to get to, and Jaimie will as well, around the opportunities with technology for addressing this, but certainly there are negative implications of that as well. Mental health protective factors: sense of belonging is one of the most important predictors of student mental health, which is not just the opposite of isolation. It's really having a connection to your campus community and feeling like you belong on campus. Meaningful relationships with faculty, students, and others on campus, and then positive health behaviors are predictive of mental health. I'm going to talk next about high levels of unmet need for mental health services. So people have probably seen in the media a lot of attention around the demand for mental health services and the increasing rates of help seeking among college students. And counseling centers are really overburdened and are unable to meet the demand in many ways. This is a study using the Healthy Minds data. And here I'm just going to highlight one bar to the far left of your screen, which is showing the rate of students who had received any medication or therapy in the past year. It's about 19%. And then you can see the rate of students who've received past year treatment in 2016, 2017, up at 34%. So a lot more students who are seeking care. That said, and somewhat paradoxically, there's an enormous treatment gap that exists on campus. So while many more students are seeking help, there's also a big proportion of students in need who are not receiving services. And these bars here show among students with depression, for example, on the far left, 37% who screened positive on this clinically validated scale, the Patient Health Questionnaire 9, had received treatment in the past year, meaning that there's a 63% treatment gap for depression. The most common barriers that students report in terms of the reasons why they're not accessing treatment are an inability to access treatment, no available appointments, stigma, and a lack of perceived need. Like the problem is not serious enough, or everyone is struggling, and why would my problem, deserve seeking help? Most students who do end up seeking treatment do so in a crisis, which is a really big missed opportunity for early intervention. There's also an important interaction that we can think about here in terms of symptoms continuing over time and being untreated, and how that may perpetuate this treatment gap as students continue to have more and more severe symptoms, are less and less motivated to seek help, feeling more hopeless about the future. And there's an enormous body of evidence to say how important it is that we are engaging young people in treatment as early as possible. And many students who do seek treatment on campus are identified by their peers or by other gatekeepers, people who come to them and say, I'm worried about you, and try to provide them with resources. So I'm going to talk a little bit more about what that might look like now, given campus closures. Equity is more important for us to be thinking about now than ever. With regard to this treatment gap, it's much larger for college students of color and for first-generation low-income students. You can see here, these are again data from the Healthy Mind study, where you can see that roughly half of white students with an apparent need, so with a positive screen for depression or anxiety, are receiving treatment, relative to students of color, where you can see much lower rates. Black students at 21% having a diagnosis, 26% having any treatment in the past year, Latinx students and Asian students as well being much lower than white students. And we put out a book chapter about the national landscape of college student mental health using all of our available Healthy Minds data at the time. And I was looking back at that this week, and we wrote in there, perhaps the most common risk factor for mental health problems among college students is financial stress. I think given everything that Dean Galea just said as well, we really need to be thinking about the financial stress that students are in right now. Importantly, untreated depression is associated with a twofold increase in dropping out of college. Students of color and first-generation low-income students have, on average, much lower rates of accessing care when in need and higher rates of stopping and dropping out of college. So lastly, some considerations moving forward. This is a brief report that my colleagues and I put out last year. And I again returned to it this week thinking about this talk, and I think that these recommendations and actions for campus leaders in responding to student mental health really hold up for this current moment in time. So we need to be assessing student needs. It's really difficult to meet student needs if we don't know what they are. Enhancing the accessibility of clinical services, of course, that is a big challenge. And I'm going to say just a few things about that. Considering opportunities to integrate mental health promotion and prevention throughout the entire campus system, and then having campus leaders that are setting the tone regarding mental health on campus through proactive messaging, communication, and norm setting. So just a small bit about a big body of work that has looked at essentially the return on investment. All of the investments that we make in promoting student mental health and connecting students to services early on are returned many-fold to institutions in terms of the tuition retained, and then there are, of course, enormous benefits to students and to society. So we need to be thinking about expanding treatment, teletherapy, crisis response, stepped and tiered approaches where we're allocating resources as efficiently as possible based on the level of need. I think we have a really big opportunity here to expand prevention and early intervention efforts, in particular life skills and coping and resilience, which can be part of a curriculum. I know there's so much conversation about students as they arrive on campus and whether or not they're kind of equipped to deal with campus life and to the inevitable setbacks and failures that they will experience. And I think that college and the college curriculum has a real opportunity here to be trying to foster these skills and thinking of this as a part of the campus mission. And everything that I've talked about today is going to require partnership across campus units. So this is sort of the ecological model coming from a public health perspective. You can think about the individual student who's embedded within a network of peers who are supported by faculty and staff, and then within the campus system. And the overall question that I'm really thinking about now is how can we be fostering connectedness, this really important predictor of student mental health, at each level during this time of physical distancing. We need efforts to identify students at risk. We need new screening and linkage efforts. Faculty are more important gatekeepers than ever. There may be potentials for brief training opportunities for faculty to be able to serve as more effective gatekeepers. And I think communication really matters. Having clear communication online about how to access services, about continuity of care for students who are already receiving services, information for students who are looking to access care for the first time, and all of the resources that are available. I think we need messaging from campus leaders to reduce stigma about mental health and treatment, and there are some great examples of this already, and we need to continue in that work. And then all of the messaging that we put out to our campus community should really be vetted through a lens of just recognizing all of these vulnerabilities that Dean Galea just mentioned, and really making sure that any communication we're making to students about potentially their on-campus jobs changing are recognizing and really expressing our support that we have for students during these challenging times. Like I said, I think faculty play a really important role. I have been organizing a weekly happy hour with our PhD students. It's a really simple idea. We just get together once a week to check in, to see one another's faces. And I try to have kind of a prompt that we can all go around and talk with. In my classes, I've been doing a rose and thorn, an opportunity for students to really say, you know, what's going on in their lives. And the first week of campus closures, the first time we had our class on Zoom, that took over an hour, and I was very happy with that. I would have let it take even longer if it needed to. And really trying to talk about self-care with students and the beauty that exists in the world, like the supermoon last night. And there's some very cool examples. I have a friend who's a faculty at UNH, and their faculty came together and did videos in support of students. I think these things really matter to students right now. And lastly, I'll just say that our response to this moving forward as campus leaders is really going to need to be driven by data. We need to know what students' needs are. As I mentioned, I run the National Healthy Mind Study, and we have just added a new series of questions looking at the impact of COVID-19. We're really trying to prioritize students' unique experiences with the pandemic and campus closures, and we'll be linking that information reported by students to other data sources. Our topics for spring 2020 that we've recently added are personal experiences, so health, economic, living situations. I can say the majority of my students are living in situations that are different from where they were living at the start of the semester, preventive behaviors that students are engaging in and their fears and anxieties, perceived supportiveness of the college and university, which I'm hoping that campus leaders will be interested in receiving that information, and then experiences of discrimination, particularly for Asian and Pacific Islander students. And we're planning a full module of items related to COVID-19 for the fall Healthy Mind Study. So I'll stop there, and I look forward to continuing this conversation.
Thank you very much, Sarah. That was terrific. Let's switch slides. Next up is Professor Jaimie Gradus, who is a professor in our Department of Epidemiology, who's a psychiatric epidemiologist, done a lot of work in a lot of these areas. And we've asked Jaimie to talk about what can we do sort of to end us on a high note from the three representations. Professor Gradus.
Thank you, Dean Galea. Thank you, everyone, for being here today. I'm happy. It's kind of a nice role to be in, to end on a high note for everyone. So as Dean Galea mentioned, I'm going to be talking about some strategies we can use now while we're sort of in the midst of the pandemic still, to bolster mental health and to hopefully prevent some of the mental health challenges that we might face in the future. I'm going to talk about how the picture might change a few months from now and the things we'll need to be thinking about then, and then how the picture might change again, going even further into the future as the pandemic ends. So now some of the most important strategies we could be using are recognizing and normalizing feelings and providing coping strategies for those that are struggling. We held at BUSPH, as part of our coronavirus seminar series, an hour on mental health in a time of crisis. I know many of my friends and family that are in this field tuned in just to get tips and learn more about this. New York State, which as we all know has been a real epicenter of the current pandemic, has tips on their website for mental wellness that people can use. A second strategy is encouraging interaction during physical distancing. So this graphic below the text is from the WHO talking about how physical distancing is not social isolation, even though many people initially took it that way when the physical and social distancing recommendations came out. And New York State also offers a crisis line for mental health for people to call if they're struggling in the midst of the pandemic. It's really important that we continue to support people that came into the COVID-19 pandemic with existing mental health conditions. So I know Boston University offers telemedicine services to students. The Center for Connected Health Policy also has a website that I'm showing here that posts daily updates to telehealth coverage policies so that people that were experiencing mental health issues going into the COVID pandemic can continue to get support, and people who begin to need support can use these resources to try to either find out how to get it or to actually get the help they need. And also, it's going to be really important during this time that we continue to try to buffer the negative mental health consequences that may be to come. And so a few ways to do this are the many social programs that we've seen rolling out over the last few weeks, including helping people find healthcare insurance or, healthcare resources, as is on this benefits.gov website. Finding out information about unemployment. And then also, I think another thing that sometimes maybe goes overlooked is the way volunteerism might buffer mental health consequences that are negative, and the importance engaging in volunteerism during the pandemic. So I like to think about the strategies that we could use to address the mental health problems that may be coming following and during and following the COVID-19 pandemic as sort of this pyramid, because we really need to build on all of the things I just described, and they're really going to need to be ongoing into the future as the pandemic rolls on and as the consequences continue to unfold. So the goal for now, while we're really in the midst of things, should be to minimize the mental health consequences to the largest extent possible through all of the methods I described. And again, this should really just be a basis that we'll add on going forward into the future as the problems evolve. So in the next few months, Dean Galea described some of this. We're likely to see increased economic fallout and the consequences of increased economic fallout. We may see continued outbreaks as we try to return to normal life and potentially have to socially distance again if we go back a little too soon. We'll see increased grief as the death toll rises, but not only due to that, just due to people really having a hard time acclimating to the new way of life. We're going to see continued life disruption. And something that I think about a lot is sort of this toll of misinformation, this idea that people are so anxious right now. And what they do when they're anxious is that they search for information. They just want to know what's going to happen. And there's so much information out there right now, some of it very good and some of it less good. And I'm a little bit personally concerned that the toll of misinformation on everybody is going to have some serious consequences for mental health. So because of all of these things, we're likely to see in the next few months an exacerbation of mental health issues among people who perhaps already had them before, but also an increased incidence of new psychopathology. That's people developing disorders that never really had psychiatric disorders before, but now have them for the first time as a consequence of the pandemic. So it'll be really important in the next few months, and again, this is all sort of ongoing over time, to decrease stigma. We really are going to want people to seek care if they are experiencing psychopathology, especially if they are experiencing psychopathology that is really affecting their day-to-day life. And so a first step towards getting people to seek care is decreasing stigma around having disorders and around seeking help. And we are going to have to increase public awareness about the effective treatments that work and increase access to these treatments. So here are just a couple of pictures of the treatment manuals for 2 treatments for post-traumatic stress disorder, prolonged exposure, and cognitive processing therapy. But there are other treatments that work as well. So we expect to see after the pandemic an increase in post-traumatic stress disorder, as Dean Galea mentioned. And the best evidence for treatment for post-traumatic stress disorder would be cognitive processing therapy or prolonged exposure therapy. And the evidence we have today suggests that as of now, pharmacotherapy is really not as effective. So it's medication is not as effective for treating post-traumatic stress disorder as talk therapy or psychotherapy might be. But there are some other disorders that we're also very likely to see following the COVID pandemic or in the course of the COVID pandemic. So generalized anxiety disorder and depression are another two disorders that we're likely to see increases in. For psychotherapy, cognitive behavioral therapies are really the frontline treatments there. But as many people on this call already probably know, there are drugs called SSRIs and SNRIs that are typically thought to be the frontline treatments for these disorders. And then finally, we're likely to see an increase in substance use. And of course, when we talk about substance use, we're talking about a variety of different substances, ranging from alcohol use all the way up to much more stronger illicit substances. So depending on the type of substance, treatments will vary. But some psychotherapies that are known to work are, again, cognitive behavioral therapies, contingency management plans, and 12-step programs. And when we talk about pharmacotherapy for substance use, we're usually talking about medication-assisted treatment for things like opiate use disorder. So again, thinking about this in terms of a pyramid, what we're going to need to build on top of the strategies that we're already using in the next few months is access to these known effective treatments to mitigate long-term consequences. And then finally, looking forward beyond the next few months, the coronavirus pandemic will eventually end. This is a headline from the New York Times, I think just from a few days ago, that the search for a vaccine is now a global competition. But as Dean Galea mentioned, a secondary mental health epidemic could be well underway. Here's an article from Bloomberg Business saying the mental health care system is not ready for COVID-19 either. And I've done quite a bit of research in this area, but in the long term, untreated and undertreated stress and trauma and related disorders are associated with physical health problems. Dean Galea showed some really compelling data about diabetes. There's also evidence for cardiovascular disease, for gastrointestinal disorders. Of course, untreated and undertreated stress and trauma are associated with other psychiatric sequelae, even after the initial disorder that might be diagnosed. So additional substance abuse, maybe on top of post-traumatic stress disorder or other psychiatric disorders. And all of this is associated with suicide. So again, it's going to be important to increase access to care for people who are struggling with the ongoing effects of this pandemic. But also, I think when thinking about healthcare systems and other systems that are tasked with caring for people like a university, it's really important to increase the understanding of the long-term effects of trauma throughout the whole system. And I think, as Professor Lipson mentioned, it's important for people to both know what to do when a student is obviously struggling, but also to know what to do when a student is struggling but can't say it, or doesn't know how to get help, or isn't able to quite come out and say what the issue is. And I think we're going to see students that fall into both of these camps going forward, the ones that are quite able to articulate what their issues are and seek out the help they need, but others that are less able to do so, but that might need help just as much, if not more. So as I envision at the top of the pyramid is sort of into the future, really anticipating these changing needs in the next 12 months to 18 months, and thinking about the ways in which untreated and undertreated stress and trauma could have long-term effects even beyond that, and how we will be tasked with helping those people that are suffering the mental health consequences of the pandemic. Thank you.
Excellent. Thank you very much, Jaimie. Now I'm going to open it up for questions. Please feel free to send questions. I'll start by triaging some questions. So first of all, I'll start with an overall question about will this be available afterwards? This seminar is being recorded and it will be archived on the Boston University School of Public Health website. You'll be able to go on the website tomorrow and get it. If you are interested in this, we had a similar, slightly longer seminar on mental health at the school with different speakers actually, then it's tackling the same issue but from slightly different angles, and you can find it archived on our website as well. We also do a weekly coronavirus seminar at the school where we're covering a range of topics from the science to the politics to how to build a better health system to deal with the virus, and all of those are archived on the school's website. I have a question for, I'll start with one for you, Jaimie. The question is, coronavirus is sort of making mental health treatment harder. It's actually creating all sorts of very practical physical obstacles for mental health treatment. How should the system adapt to dealing with that, and in particular dealing with people who have relapses and are isolated?
Yeah, this is a great question, and I'm glad to have a chance to answer it. So I think one of the major ways that this is happening right now is the increased use of telehealth and telemedicine, and people connecting with psychiatrists and other health professionals that way. I know there's been some changes in what Medicare and Medicaid are reimbursing for lately with regard to telemedicine. But one of the reasons that I sort of raised that pyramid approach to thinking about disorders that will occur months from now is that I do think it is going to be a challenge for people that are now experiencing new onset psychiatric problems as a result of COVID to get linked into the mental health care system when they haven't been in it before. You know, it's not an ideal time to try to first navigate that system. So I do think that getting people linked up to new treatment, even if, you know, the telehealth is then available once treatment has been initiated, I think it's going to be that first linking people up to new treatment initially that is really going to be a challenge. And I don't know that, I think individually there are some decent systems in place depending on the person to help people find providers. Like in some cases, insurance websites will have that information. In other cases, societies that deal with people of a certain discipline will have that information. But it would be nicer if there was a sort of easier way for people to make that connection when they're going through new symptomatology right now. And I don't know that that is something that exists or can easily be put into place. Well, I would be interested to hear what you think, actually, Dean Galea, about that.
No, I think your answer is perfect. I tend to think that we are going to, that this moment will occasion a rethink about how we do a lot of mental health treatments. And I think, you know, I'm often asked, what's a silver lining? And it's very hard to come up with a silver lining in the middle of a global pandemic. But stepping outside of ourselves, there are silver linings. And I think if this can inflect the adoption of digital approaches to mental health treatment, I think there will be a silver lining. I think we are at a place right now where everything that Professor Gradus said is entirely right. Like, this is very new territory in terms of really dealing with whole populations and using all means at our disposal, including digital means, to deliver treatment. If this can actually trigger us to actually embrace these methods, that will be a positive indeed. I'll take a different question. This was from David, and it's a mix, partly for me and partly for you, Sarah. So let me start. The question is about social media, and the question is, the first part, which I'll take, is you know, I showed the data about more social media exposure, high risk for mental illness, but could it not be that people with mental illness are likelier to look at social media? And the answer is absolutely, and it's probably a bidirectional relationship. And the data so far around COVID are not good enough to tell us to definitively show that social media leads to mental illness, not the other way around. However, from prior studies, we know that there's relatively good evidence that there's a causal link between more social media or more media in general that drives mental health. Perhaps one of my favorite studies on this looked at television watching after 9/11. At the time, it was much more television watching. And you know, there's an association, and you can say, well, if you have mental illness, you might watch more TV. But then sub-analyses showed clearly that it was television watching of people suffering that was linked to more mental illness, while other images, like sort of images of buildings and of crowds, they had no association with mental illness. So when you see analyses like that, it makes it clear that the content of the media is causative of subsequent mental health problems. So, but obviously the data will need to emerge after this event to tease it apart, but probably the answer is it's bidirectional, but almost certainly there is some direction from more social media to more problems with mental illness. Now, this now brings us to Professor Lipson, the question, the second half for you, Sarah, which is, okay, well, given that, how worried should we be about social media use among college-age students? And what, if anything, should we be doing about it, both in college students, but also perhaps extending them to the whole population?
Mm-hmm. Yeah, so I think we need to be encouraging students to examine their use of social media, that's an opportunity for them to have autonomous, you know, independent behaviors consistent with being an emerging adult, and really saying, you know, you have the control over what you're seeing and what you're looking at, and maybe it's time to go through and kind of you know, look through who you're following and how you're using social media. So then there's probably opportunities there to do some training and intervention around ways that you can kind of think critically about your use of social media. And I think it's inevitable that students are going to be, even more connected on social media now than ever. And I actually think it's really important. It's one of the ways that I have a few undergraduate advisees who I know that's really a lifeline for them right now, is their ability to communicate and to post and to share things and have people, reflect and react to their experiences. So it's definitely not black and white, all bad or all good by any means. And I do think it's bi-directional. I think it also relates to how we're spending our time. And we're all getting used to this new normal and having routines. And just trying to figure out, where does social media fit into your daily routine? What are the potential ways in which your use of social media is working against the goals that you have for your day and the ways that you intend to be spending your time? I think it can kind of unintentionally creep in and take over young people's lives.
Thank you, Sarah. Let me ask you one other question that's directly for you about the Healthy Minds study. Can you just comment briefly about your findings by demographic groups? The question is sort of by gender, socioeconomic status, race, ethnicity, just top level.
Yeah, so I had just mentioned one kind of key variation that we should be thinking about, which is students of color and low-income students having much lower rates of help seeking when they're in need. One of the most important opportunities with a large-scale data set like Healthy Minds is that we can look at important minority populations. So we know that transgender and gender nonconforming students, for example, have much higher prevalence rates of depression, anxiety, suicidality. International students have much lower rates of help seeking, along with students of color and first-gen low-income students. We've looked at it so many different ways. I'm trying to think of some of the other really interesting. We've looked by academic discipline, which I certainly can't go through all of the different ways that we've cut the data, but that information could be really important for academic departments across the university. So we know, for example, law students have much higher rates of anxiety and are much less likely to seek help. There's actually ways in which the board certification process is potentially, making it difficult for students to even access treatment because it could come back and be on their record. So there's a lot of unique things to think about by academic discipline and by these different socio-demographic characteristics.
I would encourage anybody to, when you can get the archived presentation, you'll see Professor Lipson's slides, and she has the URL for where her study records are, and there's a lot of information there. Let me take a question from Mark, and I think it's for all of us. And I can't decide if I'm glad or afraid that, Mark, you asked this question, because I think it's a really critical question, which is the impact of the lockdown and isolation, the human cost based on things we're talking about, suicides, drug use, domestic violence, etc. Is it possible that the health consequences of our consequences will be in excess of the people who are actually dying from COVID? Before I'm going to ask maybe Jaimie and Sarah to address that, and I'll give you my opinion. We actually are doing a seminar on this exact topic at the school next Wednesday, which is called The Health Consequences of the Consequences, where we have economists and sociologists discussing this question. So there is no easy answer, but Jaimie, maybe you can start and we'll move on to Sarah.
Yeah, I would just say, it seems entirely possible. I think the things that we are encouraging people to do now, although we don't have data yet on how suicide rates may be increasing during this time, or substance use rates may actually be increasing right in these very moments, the things we are asking people to do are strong risk factors for all of those outcomes. Social isolation, strong risk factor for suicide, substance use then also being a risk factor for suicide. So I think that these are issues that will just sort of compound for now. I would let Sarah add to that.
Yeah, I would definitely echo that as my concern, and certainly a priority for research moving forward. I'll add one thing just related to campus closures, and in particular for students. I think there was a lot of variation in terms of how campuses communicated their closures and the policies that campuses had for allowing students to stay on campus. BU from the very beginning said this policy includes precautions for students for whom going home is not a safer option, that the approach to this is to enhance safety. And if going home for you is not a safe or feasible option, then then we have, we'll continue to house you on campus. So that I was proud and pleased to see that was BU's initial approach rather than kind of a reaction to student need, because inevitably there are students and people for whom home is not a safe place.
Yeah, thank you, Sarah. And I think it's a really complicated question. I think it's a really important question. If anybody's interested, I actually wrote a piece with a postdoctoral fellow that's being published in Scientific American on Tuesday, I just found out, that tries to ask this question. And there's no easy answer, but unfortunately, I do think that the burden of the health consequences of the consequences is going to be large. And I worry that the long tail of the health consequences of the consequences is going to live with us for months and years. So thank you for asking that. I'm going to ask just one last question for the panel, looking at the time. And maybe we'll go Sarah, you first, and Jaimie. And so what's one thing that the audience should be doing from a point of view of protecting their mental health, protecting the mental health of their loved ones in coming months?
Yeah, reaching out to people, making that effort. I actually ended up just making a list on a notepad of all the people in my life that I should be connecting with, and just making sure, because if you don't see people on a daily basis, it would be easy to forget about someone. And I went through all my phone contacts and wrote down all the people in my life that I feel like I should be connecting with, and that in and of itself can feel a little bit overwhelming, but just making sure that I'm maintaining those relationships, I think, is extremely important for me, and I think is important for everybody.
Thank you. Jaimie, what do you think?
Sarah took my initial answer of reach out, so I will give a different answer of reach in. I would say take care of yourself, right? Make sure that you are doing what you need to do to maintain whatever it is that you're responsible for, doing self-care in whatever way you need, if it's staying off social media, if it's still trying to exercise, if it's reaching out to people when you need help. I think it's really important that, of course, we all take care of each other, but we can only do that as well as we take care of ourselves also right now.
Thank you. Thank you, Professor Gradus and Lipson. That was really terrific. Before I end, I just want to put on one thing quickly on the screen, which this is, let me make sure I share that. There's another in this seminar series that's being organized by Alumni Relations and Development at the university for the trustees, boards, and alumni leadership at the university by Professor Corley, who's the chair of the Needle, about the current experience on the coronavirus. Thank you, everybody, for joining us. Thank you to everybody who was behind the scenes in arranging this, to Steve Hall, Susan Richardson, Karen Engelborg, and to our team at the school, Alicia Noel and Meredith Brown. And thank you in particular to Professor Lipson and Gradus for giving up their time. And thank you to everybody out there for everything you're doing during this time. I hope everybody stays well and stays healthy. Thank you, everybody. Have a great afternoon.
Thank you.
Thank you.